Hello, good evening, good afternoon, good morning, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a professor in the Medical Education Research and Development Unit in the Faculty of Medicine at the University of Malaya. We're coming to you live from Kuala Lumpur on Monday evenings. Unfortunately, Dr. Pujita cannot join us this evening, so therefore bear with me as there might be a pause as I admit people as they join. We are reaching 24 countries around the globe, and our numbers are slowly increasing. Yes, you will get certificates for this evening. We are accredited by the Royal College of Surgeons of Edinburgh, and our certificates will be distributed in due course. We're a few months behind, I'm afraid. I have some very important news in that the Royal College of Surgeons of Edinburgh accredit this program, but we have started our face-to-face program in the Faculty of Medicine at the University of Malaya, and that is now going to receive accreditation as well. On the back of this, I have submitted for Spencer Large Grant to look at a full curriculum and development of skills based on what we're teaching. And that was part of the manual that I submitted to the Royal College of Surgeons of Edinburgh that has got our accreditation. So fingers crossed for the grant. I travel to the UK and the Association of Surgeons and Training meeting for the weekend of the 6th and 7th of March and look forward to meeting up with colleagues and past presidents of the association and also with Professor Angus Watson, who is the Vice President of the college and in charge of skills development, and I'm sure was instrumental in us receiving accreditation. This evening, I've called it Alignment, Vectors and Postures. And as part of my martial arts learning, I'm learning the Joe. Now, this might look like a broomstick. Indeed, it's the same size and shape and length as a broomstick, but it becomes a lethal weapon in the right hands. This can defeat somebody with a katana. The reason for it, because it is long, held properly and directed between your eyes, it's threatening and it keeps you at a distance. Amongst the many strikes that you learn, and this is the basic stance and position that is holding you at a distance between your eyes. But if you come down with a sword to strike my head, I immediately go up to this position. Now, the sensei describes this position as my left hand as the level of my shoulder, my right hand as in front of my left eyebrow, and the Joe is angled at 45 degrees to the floor and 45 degrees out. The reason for that is to catch the sword, and having caught the sword and prevented it from cutting me, I then swing it away. And that swinging away throws the sword behind the attacker, and I follow up by putting the stick between his eyes. It's incredible that the angles of this are really critical and important for this to be effective. Now, what is known in coaching in sport begins not with movement, but with posture and with setup. So before speed and power, before strategy, there is alignment. And the best coaches understand that performance is built on geometry, angles, balance, base of support, and relationship to the environment. Sound familiar? It certainly does. And do you consider circular sport? Well, posture is the foundation of power. Now, we don't teach you speed. We teach you correctness of technique. And with correctness of technique, your diastolic interval, the wasted unnecessary movements are reduced, and you end up with flow and rhythm. In sprinting, coaches such as Usain Bolt's long-term mentor, Glenn Mills, emphasized a tall, natural posture, neutral head alignment, and stacked hips over shoulders. Bolt's acceleration phase was not just about leg speed, it was about his body angle relative to the ground. A few degrees too upright or too folded would dissipate the force and reduce his acceleration. We know this in many sports. In golf, coaches working with Tiger Woods repeatedly rebuilt his stance, spine angle, knee flex, grip pressure, and ball position. And before the swing begins, the geometry is already determining the outcome, a bit like me holding the judo. I either survive the blow and throw the sword out the way, or it slips down and cuts my hands, or misses altogether and splits my head. You see, poor setup guarantees compensation mid-movement. And we'll demonstrate this with stitching. In basketball, Stephen Curry's shooting coach, Brandon Payne, focuses obsessively on foot placement and shoulder alignment before the ball leaves the hand. The shot is won or lost in the setup. You see, setup determines decision-making and speed. In tennis, Roger Federer's elegance was rooted in early preparation, unit turn, racket set, balanced stance. Because posture was correct early, he had more time to decide. Coaching here is not about buying cognitive space through mechanical readiness. So you set up and align, and then you're ready. In martial arts, particularly in ultimate fighting, championship athletes, stance width and guard height dictate both offensive and defensive capacity, and a poorly set stance slows the reaction time, limits technical options. Posture also reflects psychological state. You see, when people walk onto a stage to present, standing tall with the shoulders back and chin up, there's an air of confidence that is immediately transmitted to the audience. Orchestras can tell whether they will play with the conductor or not within 30 seconds of them walking on the stage. In sport, in rugby, teams like the New Zealand All Blacks, and I'd say the South Africans in particular, emphasize body position, not only in scrummaging, but in presence. And the All Blacks are famous for the haka. You see, upright posture signals readiness and dominance. Slouch posture reflects uncertainty, and coaches understand that physiology influences psychology. One of my senseis, Alice, is into Olympic weightlifting. And in Olympic weightlifting, coached under systems influenced by Pyrrhus Demas, athletes are trained to own the bar before the lift. Chest open, lats engaged, feet rooted, and the lift begins before the movement. Elite coaching around posture often follows three important steps. One, visual alignment. Is the athlete stacked and balanced? Is the surgeon stacked and balanced? Two, kinesthetic awareness. Can they feel neutral versus compensatory positions? As you operate and engaged in dissection and anatomy, are you aware of your body position? And I am just going to let a lot of people in. I think, admit all. And are you aware of body position? You see, small changes produce disproportionate gains. So posture and setup principles extend into music, into leadership, and into surgery. The violinist holding the violin, the flautist holding the flute, and one of the ENT surgeons in Bradford who played in the Bradford Orchestra said he could not produce a note unless he's sitting properly. For the surgeon, that is holding the curved needle. All succeed and fail based on the setup before the action. So coaching, therefore, is less about shouting, instruction mid-performance. It's more about engineering the starting position. I love the phrase, the body obeys geometry, performance obeys posture. And that is exactly what we are trying to teach in surgery. My sensei in the dojo from the end of the room can pick up the wrong position. And if you're rigid and there's no flow, you're not able to translate your position and angle into a rotatory force that throws the sword behind the assailant. So we come back to posture again and again and again, because when you put it together with the alignment and the vectors as previously described, you'll find that the process of operating is not actually standing still. There's a lot of dynamic movement. And movement can also be with the table and the tilt, as we will explain. So let's go back and just demonstrate some of these things, and you can start thinking about it for yourself. Remember that 92% of surgeons will end up with some musculoskeletal degeneration during their lifetime. And that is because we are not taught or trained or coached to stand properly at the table and to use our needles. I've actually had fusion of C566, and I can say I've got radiological evidence that I've got my head screwed on. Some people would actually say, well, we're not sure if that's screwed on correctly or not. Joke, ha ha, funny. But point being, 22 years of cardiac surgery, and I had severe degeneration in my neck. So let's come over and highlight some of these issues. And we use, as you know, the banana model. The banana we have put in a CT scanner. It's 40 to 80 Hounsfield units. Suture pads are 240 Hounsfield units and do not reflect the consistency of tissue. 40 to 80 is your normal Hounsfield unit density of the aorta, of the bowel, and of soft tissues. Not only that, we have previously pointed out that the banana, because of the phenol oxidases in the skin, turns black with damage and gives you immediate visible feedback as well as haptic. Just to reiterate, your position of the needle, because you're standing, is on the halfway, or just after it, depending on the size of the needle. It's at the tip of the needle holder, so there's no space between the tip, and this angle here between my nail and this needle mathematically corresponds to the horizontal and my forearm, reflecting the displacement of the wrist from the elbow. The pickup, as we previously said, is 1 at the halfway, 2, no space, and 3, angled out. The alignment was aligned according to 90 degrees, mathematics again. And it's 90 degrees across what you want to stitch and 90 degrees into what you want to stitch and 90 degrees to the tissue. So those angles are fourth part of the circle, and it's 90 degrees in every orthogonal plane. This simple alignment is the principle behind good and accurate stitching to avoid displacement and dislocation. So we said last week, your needle has to be 90 degrees to the tissue, 90 degrees across what you want to stitch, and then 90 degrees into what you want to stitch. And the banana standing in one place gives you these angles. Place, rotate back, point, and rotate. Remembering that the distance that you go in and come out should be same, and also the needle should come out opposite where you put it in. We deliver the needle iteratively, apply the needle holder at the pickup point, continue the rotation on the curve, and deliver the needle, and start again. That was the first stitch. The second stitch, by placing, I can visualize the spacing. From there to there, I want about a centimeter. Pronate back, point precisely into the tissue, and use the needle to rotate it out. And I lost control of the needle there, and that's why. Oopsie. I think there's, yeah, those swap needle holders. So place, rotate back, point, that's pronation, point, iteratively rotate the needle through the tissue, and that was too deep, and I'm pushing it too deep, and I'm grabbing the top of the needle, and you're not supposed to do that. Place, pronate back, point, and rotate. Now, as I'm coming down this and thinking about my needle coming through each time, I'm thinking about the setup, but there's something else that is going on as I'm coming down this banana. And I will demonstrate that to you with a longer incision. If I'm standing straight to the table and I've aligned my needle there, place, pronate back, point, and rotate it there, so it comes out on the line. I have to, between there and there, change my body position. Because if I don't change my body position from a weight distribution of probably 70-30, right leg to left leg in that position, to more a 80-90 position down here. The thing is that what happens as you come further down the wound in a horizontal direction, if you stand still, to keep it straight, you'll find that your elbow is moving away from the body. And I just want to come up a little bit and just demonstrate that. So I'll see if I can get the right camera angle. So what is happening from here down to here, my elbow is actually starting to abduct further and further and further. And as we have previously demonstrated, when you stand with your elbows out, your scapula has moved across the chest wall and is held by 17 muscles. So by the time you get down to the bottom position here, on a long incision, you will find that your elbow has left your side. Your scapula has to be fixed to the chest wall, and you are now struggling in the position. Not only that, you're starting to bend at the hips and the waist and the lower back to try and compensate for this progression down this linear incision. The other thing that happens is that you start off with your needle mounted 1, 2, 3 as a pointed here. You start off 1, 2, 3 in the right position, but as you find, and I've noticed with people, particularly doing a continuous stitch along 10 centimeters is enough. The needle, and I'll use a straw, the needle goes from the correct position to and migrates like that as you go further down. And people are so focused on the stitching that as you come further down, what's happening is the needle is losing that angle, it's coming more 90 degrees, and it's migrating down into the jaws of the needle holder. So by the time you get to this position, your needle alignment is completely wrong. It's not at the tip, and you've lost the pickup and ability to place, because now the tip of my needle holder is touching that banana and not the needle. And if I try and take a stitch, I'm not going 90 degrees into the tissue. I'm now lost the rotation and control of the needle altogether. It's torn the banana going in and torn the banana going out. So I see this regularly. I saw this regularly, particularly in cardiac surgery, because we had a 20 centimeter incision to close the muscle and the deep tissues. And people would actually stitch, 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 stitch. And by the time they started the top, they picked the needle up correctly, they lined it properly, they took the first stitch correctly, and then they're in such a hurry to get to the end of that incision that each time they picked it up, they lost the alignment, but that did not stop them from continuing to stitch, because the priority was to close this as quickly as possible, because the action of stitching was considered more important than the setup. My point being is that with a continuous incision, unless you're attending to the setup each time, by the end of that incision, you would have lost complete control of that needle, found yourself with your elbow sticking out, having to support your scapula, contorting your body to compensate for bad needle angles, and totally ignoring the fact that the needle is now ripping through the tissues as it is with this banana. Wrong. Totally wrong. So this is further exaggerated. This is a linear progression. But what happens in this situation? I've got 3 incisions here, and you can try it yourself. And it's worthwhile doing this on a banana at home and working out your body position. First of all, this is what we started with, 5 stitches. And we want to come in on the line, and we want to come out on the line. Up, see, it's off to the side. We start again. And I'm pushing it now, and I'm not iteratively putting the needle through the tissue. And therefore it's disappeared into the banana altogether. And I'm not using the rotation of the needle. Well, that's all very good. But what about this side of the banana? How do I stitch in that position. I'm in a fairly neutral standing position here with my weight distribution more or less 50-50 because the incision's in front of me. At this side, if I'm standing in a 50-50 position, I am not going to get my needle properly aligned without turning my body. And to get to this position, I'm finding my elbow has left my side, increasing the strain and the muscle that I'm using. What I do is step to my right. I am now on my right leg. Effectively, I've stepped towards my abducted short arm. And now I'm in the right position to effect the rotation. I'm definitely losing the needle in the banana this evening. Definitely losing the needle in the banana this evening. That's the thing about doing this live. You can see the errors as I see the errors and feel the errors as well. And that's off to the side. That's on the line, same distance apart. It should really take it through. Do not pick the needle up at the point. Continue to deliver it to the pickup point and do it again. And I've maintained the alignment and position. But what about this side? If I don't move my body, I now, to get to this position, almost have to bring my elbow beyond where it's anatomically possible. So at this end, on my right, that's on my left side. On my right side, my elbow doesn't come far enough in for me to make that alignment. I therefore have to change my body position. And I've changed my weight distribution to my left foot. I now can align the needle properly and take the needle through the banana. Same distance on the line, deliver it to the pickup point, and a little trick, as I take it out, I'm just going to give it a little shift so I can get the angle for the next stitch. I'm aligned, ready to go again. So I want you to appreciate that between there and there, you have got two vectors, 90-degree vector there and a 90-degree vector there. That's 90 degrees across the tissues. And if I then measure that angle, you can see between those vectors that I'm at almost 100 degrees subtended between the vector from that side and the vector from that side. I therefore have to move. Sometimes the movement is a lot more subtle. And perhaps I can demonstrate that to you with needle holder or with a pencil. I'm going to hold a pencil out towards you, pointing at you. I'm going to turn to my right leg and put my weight on my left leg. And you'll see my weight distribution, right leg, left leg. There's a subtle movement across the horizontal there. Right leg to the left leg. And when standing at a table, do not stand with your knees locked out. That will seriously increase and worsen the tension in your back. Stand with them incompletely extended. So imagine that you can move your legs without moving your body. But you can also change your body position by simply changing your weight distribution. And that little angle gives you the opportunity to get the 90-degree alignment correct. But these little angles are not only you making the angle. Remember, you can also change the height of the table. And most tables have got a gimbal. So in other words, you can tilt it So a couple of degrees this way and a couple of degrees this way will totally change your alignment of the needle, particularly at depth. And Prof. Sile was asking last week, what about stitching at depth? Well, then it's more important to engineer your starting position to ensure that your alignment's correct and you're able to effect the movement without any interruption. So what does this mean for when you're going round a circle? Well, let me just show you, because now, as you know, we're going to move to stitching around a circle. And when stitching around a circle, the alignment of 90 degrees is effectively 90 degrees to the circumference. One usually starts stitching towards you, always. So from here, and I'll use the bigger needle so you can see, from here, I would start probably at the 10 o'clock position, standing on my left foot, aligned. I then come to the 9 o'clock position. And as I come to this position, my weight distribution from being on the left foot is now coming towards right foot as well. This is about 60-40 left and right. Here, about 50-50. I'm now coming around this side, and my weight distribution is moving to my right leg. And then to this side, I am standing predominantly on my right leg, and I'm now in a position where I'm stitching towards my shoulder. This presents a problem because this is the most difficult stitch you could possibly do. And it's in this position that one has to change your needle to backhand, and you completely move your body position from your right leg to your left leg. And it's between, in my case, 4 and 5 o'clock. So my 4 o'clock stitch is now standing on my left leg, and it's backhand. And you'll find as I go from 4 o'clock, 3 o'clock, to 2 o'clock, to 1 o'clock, I'm adjusting the needle to 12 o'clock. I have now moved this position from my left leg, coming back to a more neutral position, and my weight transfer now is moving to my right leg. And there it's backhand. What you notice, I am now diagonally opposite where I started. This too becomes a problematic stitch. And it's in this position, therefore, I need to consider rotating my needle over to forehand. Note that I deliberately did not use my forceps, and I pirouetted my needle over its point. And in doing so, because of that angle, I could pirouette my needle over into the forehand position without using my forceps. I'm now stitching here at 10 o'clock, left foot, 9 o'clock, 8 o'clock, 7 o'clock, 6 o'clock, 5 o'clock, and I've moved from my left foot all the way around to my right foot. In doing this, I've minimized the abduction of my shoulder, and I've maintained the control of the rotation of my needle as my forearm is relaxed, and I can pronate and supinate with ease. What's interesting when watching people stitch around a circle, and our black belt skill is exactly that. We take a banana, we use a 2 centimeter apple corer, take off the skin, And now you have got the perfect model to practice what we've just described. The thing about this model, it is fiendishly difficult. It is difficult because it is unforgiving of poor setup, poor alignment, poor understanding of vectors, and poor posture. Firstly, we'll start here. Imagine the clock, 12, 6, 3, 9, and I'm going to go in at 90 degrees of the vector. So imagine I was drawing lines, and I have to imagine lines as I'm going round. So if I did, it's quite easy, this one, 3 and 9, and 12 and 6. But what's interesting is people's perception of 1, 2, and you see that? It's not so easy. You try drawing lines on a clock and getting those angles right. I've done a little study thinking that there would be a difference between medical students and expert surgeons. And to date, looking at it, I haven't analyzed it in detail, but to be honest, I cannot see an obvious difference. The thing is if I'm not attending to my pickup and angles in each of these things, and I become lazy, what happens is I can't rotate the needle properly through the tissue. You see that my needle holder now is tearing into the banana. But I'm so focused on the stitching, I'm not going to look at that, and I'm going to try and continue going round. And what you notice, my alignment is not there, the banana is being mushed, and I'm coming to this position, and I'm trying to get it through. I know I have to go to backhand in this position. I try and go to backhand, and I don't point the needle into the tissue, and you see that it mushes the banana. My forehand to backhand space is 2 hours rather than on the hour, and the rotation around this banana is actually getting worse and worse and worse. All because I'm more concerned in stitching on the hour, around the clock, to the clock, rather than setting up and thinking about my posture, alignment, and vectors. And at the end, you've got an awful mess where the needle's been torn through, banana's been mushed, there's not equal spacing, and I was focusing just on trying to do this quickly. Not accurate, not a pleasure to see, not good stitching. And this comes back to, it's more about engineering your start position than it is about stitching and stitching and stitching. An ellipse is just the same as a circle. It's just been squashed. But where are your vectors and alignment here? Well, if I look at 90 degrees across this side of the wound, that's 90 degrees there. If I look at 90 degrees there, that's 90 degrees there. All right? So if I were to try and take a needle through both sides in one go, all right, and then torque it round, not only do I miss it, but look at the damage that I'm doing as I'm trying to get it round the corner. And too often I see surgeons trying to do exactly that. Take it through one side and talk it through without letting go of the needle, thinking they can take the needle through the other side. It's causing significant damage to the tissue. When the two vectors are not aligned, you have to, by definition, take your needle through on two separate vectors. And the trick in doing an anastomosis, an end-to-side coronary, or a patch on a femoral vessel is that you're in and out on that vector and in and out on that vector should be aligned and opposite and equidistant from the edge. And that only comes if you pause and think about your setup and you think about your vectors. So what happens at the end of the wound here, I hear you ask? What's 90 degrees to that? Well, it's quite easy to think about, really. 90 degrees is at the very point itself. And if you notice, that is parallel, usually, to the two edges of the wound. From there to there. And your needle alignment here is people are so worried about hitting the back wall that they try and push it under and then come up to the heel or toe. But what you need to actually do in this situation is use your needle, push your posterior wall away, and now your needle can come up perpendicularly through the anterior wall of an anastomosis, and you'll never pick up the posterior wall. So the banana is offering you in these different shapes an opportunity to look at and find and play for yourself and work out for yourself what your body position is. The most important element of all of this is the alignment. As I'd said before, we've got to be able to align going in and out of the same position. Thumb to thumb, index finger, middle, ring, baby finger. If you're not aligned, dislocation. If you're not going in and out at the same distance from the edge of the wound as the tip of my fingers are and the creases of the skin at the DIP joints, you end up with a slip. And the problem is with most stitching, if you don't think about your vectors, alignment, and your posture, you have a dislocation and slip, but it probably also applies to dislocation and slip in the spine, and injury and fatigue. So what's interesting about learning martial arts is it's not the force. It's the way you set up, the way you angle, the way you hold the stick, and the position and your posture to catch that falling katana and flick it away. There's no force whatsoever. And I'm always remark at the skill of the sensei in demonstrating these. He's smaller than me, but his power and his force and his direction is so much better because he has thought engineered the starting position. With that, I'd like to ask my colleague, Prof. Sile, who's a fellow sensei, to join us for conversation and invite comments or observations from you in the chat. Any thoughts? Any observations for anybody? Prof. Sile.
Hello.
Hi.
Can you hear me, Prof?
Yes.
Um, I think his view is blocked. Yeah. Anyway, thank you very much, Prof. Because we've been practicing this is suturing and surgery. But I must tell you the truth that we never learn or we never been taught, you know, how the body posture and the legs posture and all that. We felt like, thank you so much. Yeah. We felt like this our alignment become like automatic, you know, on a lot the along the way when we were doing surgery. We did not realize that how we change our left leg and right leg and our body and shoulder and all that. In fact, we were not taught. Yeah, that is for sure. But I think along the way when we were doing, then we change our position according to our needs.
Indeed. It's
Yes,
it, it's your body shape and body position. And that's why I say these models enable you to play and explore for yourself. But the
sure.
principle of alignment of 90 degrees for the needles, of 90 degrees to the tissue, across the tissue, and into the tissue, is a fundamental principle to help you work out your body position. But you certainly don't want to be finding your elbow drift as you're coming down a long incision, and it drifts and drifts and drifts. And it's out there by the end of it. And then trying to compensate for poor pickup of the needle and poor alignment, then you're hunched over in a very funny position trying to stitch. And we unconsciously do that because there's nobody there to actually pick you up on doing this. Which is interesting because learning the katana and learning the jo, the sensei might be at the end of the room, but they can see this and they can come up and move with Joe is a little bit more. So I stood there holding this Joe in the right position the other day, thinking I had it. And he came along and just moved it 2 centimeters. I thought, wow, even from the end of the room, that 2 centimeters made all the difference. Made the difference between catching the blade and flicking it away, or the blade slipping down and cutting my hands. 2 centimeters, if that. And you think about that level of precision and that level of alignment and vector, and translate that into thinking on how we teach and instruct our juniors, then I'd say there's a simple rule with this. If you're finding yourself struggling, and if you're finding it doesn't feel right, in other words, it's not smooth and it feels awkward, stop. Stop, put your instrument down, stand up straight, drop your shoulders, put your elbows by the side, and start again. Pick the needle up properly. 1, 2, 3. On the halfway, depending what you're stitching, at the tip of the needle and angled out. Then do your alignment. What is interesting is that people are so fixed on stitch, 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 to actually effectively stitch and be effective in the sport, you have to engineer the position. It's set up stitch. And this is it. In the cardiac cycle, systole is fixed. Systole is the action of the needle going through the tissue. Diastole, as you know, shortens as the heart rate speeds up. But diastole is the setup. So if you set up, stitch it, set up, stitch. So the time it takes me to put a stitch to the tissue and you, Prof, is the same. And the time it takes you to do a stitch and me to do the second stitch will be the same. But the time it takes the trainee to do the second stitch compared to you and me is vastly different. And that is different because nobody's taught the setup, the posture, the alignment, the vectors. Once you understand that, and once you practice that on the bananas and work it out for yourself, you'll find it set up stitch, set up stitch, set up stitch. And the time it takes you to operate, because there's no wasted, useless movement, no hesitation, deviation, interruption, or repetition, then your operative time reduces. Not because you're stitching faster, far from it. you are setting up properly and consistently all the time. So what you see, and is in OSATs, is fluid motion. It's fluid because your setup is rehearsed. So when teaching in martial arts and the katana, they break each of the parts down in a kata to different parts of the waza. And you got to get that right and position down. But in the end, what you're looking for is a continuous movement that is accurate all the time, that you don't have to worry about the setup. And the practice should be focusing on the setup all the time. When you can see that and feel that and recognize that you're not aligned, that your body posture feels awkward, then, and you're correcting it each and every time, then you'll find that your operation becomes easier and more relaxed and more fluid. But there are obviously little tricks with this as well, knowing how to position the assistant, knowing which instruments to use, knowing how to angle the lights or the cameras, and understanding that you can get extra angles by tilting the table away towards you and dropping it. And you can go around the other side, because remember, perception from the left and the right subtends an angle, funny of that, about the same, 90 degrees. So it's being aware that you have options in your operating. And this makes the difference between an expert operator and a beginner. But as you point out, Prof. Seeley, I don't see this being reinforced in any basic surgical skills programs. And I'm going to ask our yellow belts and red belts to do a study to actually look at all the pictures of skills courses and examine and comment on how instruments are held and how needles are mounted. I know our fellow sensei, Chris Cuddy, is in Australia. He's online, but has not joined us. He's probably listening. But when you see it, you can't unsee it. And if a picture tells 1,000 words, do have a look at the way people are holding instruments and mounting the needle. And you will know in the silent mental corridor, Prof. Sile, there's a great picture, and I like it. It's called Inspire. And the surgeon is hunched over, but the way they're holding the instrument and the way the needle's held, it viscerally doesn't look right and doesn't feel right as well. And if pictures tell 1,000 words, well, I've suggested that we should have a censorship board looking at the correctness of the pictures that are put out there. So visually, people start to understand that posture vector alignment is of vital importance. Proceed.
Prof, there will be two situations, we encountered. When we do laparotomy, we have a quite spacious to move, our body. For example, it's like we usually stand on the right side of the patient.
Yes.
And then when we operate, and then let's say if like, for example, hysterectomy. So when we want to, deal with the vault and all that, sometimes we will move, okay, I will tell the assistant, let's change the side, yeah. And so when my teacher, my mentor, but he is so skillful, so he can do everything from his side, from the right side. But what I learned from the other consultants, Prophet Azmi, sometimes he say, Celia, why don't we switch the position? So it's like we change the side. So surgeon will go to the left side, and then assistant come to the right side. And then this is how, but it's like at the end of the day, this the safety, the surgery, it's like we don't force ourselves fixing at the one side, one place, but we move around. Yeah,
Just
that is
thinking about a hysterectomy then, Prof.
sure.
If you're standing on the left-hand side and you're right-handed, and if the patient's head to my left and I'm standing on the patient's right-hand side, I'm having to go down into the pelvis this way, aren't I?
Yes,
And
definitely.
my movement on my right arm is counterintuitive. Whereas if I was standing on the left-hand side, I'm peering down and my right hand can reach into the pelvis. So
Yeah,
I'm just wondering if that's I've noticed an cardiac surgery, certainly
sure.
stitching the right coronary artery. What happens with that in the posterior descending artery? It's right underneath you. So you are standing over, and the angles, because it's underneath you, are a lot more acute. The easiest thing to do is go to the opposite side of the table, which opens up the angles and allows you alignment and rotation. So I just wonder how many pelvic surgeons stand on the left side of the patient if they're right-handed? And would it be easier if you on the left-hand side of the patient?
Yeah. Um, we are still okay if we do the upper part of the pelvis. For example, large, huge uterine fibroid,
Mm.
hysterectomies, myomectomy. We usually stand on the right side of the patient. But if we want to deal to the pelvis, behind the bladder, then we might swap to the other side.
Right.
That is a reason when we do laparoscopic surgery, in a pelvic dissection, the surgeon used to stand on the left side,
Mm.
in a laparoscopy. So
Mm.
it's like I myself stand, being as a surgeon, stand on the left side of the patient, and then do a laparoscopic surgery. Yeah. So this is in at the like laparotomy, either laparotomy or laparoscopy.
Mm.
But when we do a pelvic surgery, being as a surgeon, it is and also assistant, very limited, yeah, space. Patient
Mm.
on lithotomy, and then, for example, pelvic floor repair, like UV prolapse, cystocele, rectocele repair, or perineal repair, for example.
Mm.
Very simple episiotomy repair. It's like we were very limited between the two legs of the patients, and plus assistant. Sometimes assistant might twist the body,
Mm.
right, is struggling because we being as an assistant, so we know that how it's painful, the twisting the back. So when I become a surgeon now, and then I always remind myself to check the assistant whether the he or she is twisting the back and in a bad procedure. When you mention about the sucker, then that reminds me for the cone after cone biopsy, we repair the cervix.
Mm.
So it's like we have to suture for 12 o'clock, 6 o'clock, and 9 o'clock, and 3 o'clock. And then anytime we need it, we put the stitches as well. So that's remind me, your
Mm.
banana
Mm.
sucker sutures.
Mm.
So that's
Mm.
very great, Prof. Yeah. And another one is that the cervical sacklage, when the cervix is loose and, have a recurrent miscarriage in a second
Mm.
trimester. We have to stitch the cervix like a pass ring. We call
Mm.
it a McDonald suture, so it's like, then we have to place it at the 12 o'clock, 9 o'clock, and we revert, the needle to the
Mm.
6 o'clock and 3 o'clock. So in
Mm.
order to get a pass string at the cervix, yeah.
Mm. Mm.
So that is the reason for the cervical sacklage needle they design with the two needles at the both end.
Ah, right.
Yes,
Interesting.
yes. So it's like that's why it is for us for very the easier to put it, that's
Mm.
reverse stitch. Yeah.
Mm.
So that is the way we are doing, Prof. Thank you so much.
Well, thank you for those insights. You always add so many valuable insights, Prof. Seeley, and it's much appreciated. Any comments from anybody else? Any observations from your point of view, Adesh?
Sorry, Prof.
Well,
I'm passively listening.
sorry?
Sorry, Prof. Was passively listening.
Okay. All right.
Yeah.
So,
Hi, David. Can you hear me?
I can hear you, Sensei Kevin,
Yeah.
from Oz.
Unfortunately, I don't seem to be able to get my camera on, but it's been fascinating watching you because I could feel your pain and agony as things weren't going quite as you wanted them to do. You were trying to will the needle to go in and out where you wanted it to go.
It didn't. Some days it did.
Well, but you highlighted that, and it was very instructive if people were watching it. And so they need to understand, even though you know exactly what to do on the day, it may not happen.
It may not happen as the way it
and that's why you have to keep practicing it until you get it just right, and you can't get it
until you
wrong.
can't get it wrong.
Yeah.
Until you can't get it wrong. But as Prof. Sile says, that the setup, alignment, and posture is not actually there. And when you look into the description in sport, all sports, it's there. It's the very foundation of the instruction in the beginning. And you think to yourself, as Prof. Sile says, it doesn't happen in surgery, does it?
No.
No, funny that.
So that's why we're training the next generation of medical students and junior doctors to think about what they're doing.
Exactly. You've got to start from the bottom up, haven't you?
Yeah. So they don't have to unlearn everything that we learned subsequently.
No, and it's very easy to pick up bad habits, and it's very important to get the technique right in the beginning.
Yeah. But I think that's where the face-to-face meetings and the gradings are going to make the difference.
Well, indeed.
What currently happens is people go on a one-day basic clinical skills course, practice it once, and then forget about it. And they don't have that opportunity to hone their skills.
Well, number of points, as you say there. One, they don't have the instruments. Two, they don't have the syllabus. Three, they don't have a model they can use. Four, nobody's actually watching their practice. And it's one-off and not longitudinal. But as you say, this is exactly why we're running the Black Belt Academy of Surgical Skills.
The other thing you pointed out there was that your sensei from the end of the hall just looks at your posture and the way you're holding your katana and knows exactly what you're doing wrongly.
Or the stick.
But he can see what's happening.
Yeah.
But you as the practitioner have no idea what you're doing. You think you're doing it perfectly.
Yeah, but it's amazing. Unless you're practicing and you're not looking at that 2 centimeters. And what's interesting that in EIDO, we are in a hall where there are mirrors both sides. So you can look in the mirror front and back and check your position each time. So you're literally reflecting on your position. Having been pointed that out, you have to remember that position and hold that position. And quite a few of the practitioners, when they practice, would video themselves doing a kata and then play it back and critically analyze it and look for the same things and same errors. So you practicing, you're reflecting and practicing and taking that out.
Yes, but the problem with that model is you're looking at the reverse image of how you're actually doing it. And so you have to deconstruct that.
Yeah, it's still very valuable. And I've been thinking of this reflection element and thinking that Ria Lang, who's in Brisbane, she's a dancer, and dancers also practice in studios that have mirrors, and they're watching their movement. On golf courses with a golf pro, they've now got videos and cameras looking at this. But it's the whole movement, not just the hands. It's the whole body, the posture, and the alignment that counts. And that is where online surgical teaching is useful on one hand, but I think there's over-reliance on it, and we do need to have regular face-to-face with proper senseis who correct you and stop you embedding bad habits.
Well, they provide you with feedback.
Correct.
So it's not about correcting, it's about saying, well, what are you doing? So
Correct.
you can see exactly what they're doing, but it's important that they see it for themselves.
Indeed, indeed.
And a lot of that comes, how does it make you feel?
Yeah,
So it's the position of your whole body as
indeed.
you're setting up that you need to be aware of.
Yes.
And when you're not completely in alignment, you need to be thinking about how you realign yourself.
And that's the point I made, is that if you find yourself feeling awkward and doesn't feel comfortable, put your instruments down, reset, realign. But what's great about the banana model, you've got visible and haptic feedback on the banana. I mean, total massacre.
Absolutely.
And that's what you need. And that's what you need. Well, thank you very much indeed for joining us at the Black Belt Academy. Please actually spread the word. I've put the feedback form in the chat. Thank you very much for joining us and look forward to seeing you next week. Thank you, everybody.